Hello, welcome to AI in Action. Today we are going to talk about if AI can save rural healthcare. This week, January 2026, Rural Health Transformation Program is hitting. I believe it's what, $10 billion is what they're going to start with.
50 billion over 5 years, 10 billion a year.
10 billion a year over 5 years.
Yeah.
And what this is it's a grant. And basically
It's a big one.
it's a very big grant, and they are going to be trying to save rural healthcare. And why is this important to us?
Because we're rural.
Because we're rural. So let's talk about this. That's what we're going to cover today in this podcast.
Just to make sure I'm clear on this, this is called the RHTP. The $50 billion is an RHTP grant.
Right. RHTP stands for Rural Health Transformation Program.
Okay, I'm not ever going to remember that. But it's interesting to me because not just because it's rural, but because, first of all, I didn't even know about it, which means I'm not paying close enough attention.
No, you have not.
But it's not AI focused either. But it's not AI focused. But it does potentially have the AI potential for things like, I was reading about this AI scribe, ambient AI scribe tool, which is supposed to help with doctor burnout. The interesting thing about that is I think that's what our local doctors are already using.
I don't know, but it's
I think they're using some kind of scribe tool. But if you think about it, if you're going to do a scribe tool, you're going to have some kind of guardrails. You can't just throw it into ChatGPT or something and say, hey, transcribe this for me. I would think it would have to be some way of kind of cross-checking for mistakes. I know how I would do it, but I'm not sure how they do. So the question then becomes is this something we can actually afford in a small town, or is this going to be yet another one of those, what was the term, tech tax?
Oh, is that what it is?
I've heard that term.
Tech tax.
It's called a tech tax. Basically, it says if you're using this technology, it's probably costing you more money and you're getting exactly the same as before. So let's hope that's not the case.
All right, so what I want to talk about, Jim, is I want to talk about the tension that this is going to cause. We have a doctor shortage in rural America. Now, we are very lucky in our town, in Llano. Not only do we have one large clinic that has doctors that still come to that clinic. It's a small clinic, but it's owned by a large corporation, and they haven't shut it down yet. But we also have a concierge doctor. He left that large clinic and he started his own.
And why did he leave that large clinic? Why did he leave? And the physician's assistant left.
Well, because of all the paperwork and the salaries and just all the stuff they were having to go to. Yes, I mean, exactly. They were spending all this time doing all of this work, and they didn't feel like they were actually helping the patient. They were working for the large corporation. Totally different podcast we can do on that. But 60% of rural counties actually don't even have an OBGYN. I don't believe that Llano, especially, and I know we don't.
No,
we
we
do
don't.
not have an OBGYN.
Closest is 30 miles away.
That we have one in the county.
Yes.
But we don't have one, but it's a very large county. I remember they were celebrating when a nurse practitioner came in that was specifically working just for female healthcare.
Think about that for a minute. Llano County is 933 square miles. If you're on the western edge of Llano County, it's probably like 50 miles to get to that clinic we were just talking about, or the hospital that says the OBGYN. It's not just that. Like today I was talking to someone, they're closing the local physical therapy place.
And they only came in, one day a week?
No, it was more than that, but they were having trouble hiring people to come in because they don't pay enough. So now they're closing it, this same large corporation you're just talking about, and they're consolidating it into a town, which is still part of Llano County, but it's 24 miles away.
25 minutes.
My mom goes there. It's been real convenient.
We have to drive her to
now we have to drive her to physical therapy 24 miles away, which is going to take a lot more time. So anyway, we're supposed to be let's talk a little bit about this program. I hadn't heard of it, so I've got some headlines I pulled up here that I wanted you to kind of look at.
Okay.
It is part of the One Big Beautiful Bill Act. That's a mouthful.
Okay.
But it's supposed to help rural communities. And you and I were on a board. We were in a group that was trying to save the local hospital.
And it didn't work.
Well, no, I think it's still open. They may be getting funding from this. It's still open. Pat, the guy that was on there with us, I think he's like the CEO or something.
It was to save the hospital it was the company that had moved in from elsewhere, and that company has since left Llano, and now the hospital is back under county
That's
control.
right. It's like the third time.
So it's the Llano County is what is still running the hospital.
Yeah, and what is it? It's a helipad for transferring other people.
So the strategic goals of this fund
RHTP
program,
yes,
is to make rural America healthy again.
Okay.
To support rural health innovations, new access points, promote preventative and give like preventative health.
Yes.
And all that stuff.
Yes.
I would like to say that yes, that is a thing in rural America, but let's face it, it's a thing in America, period. There's not a lot of preventative care that goes on in America.
That's the part I like the best.
Tech innovation.
Foster the use of innovative technologies that promote efficient healthcare delivery, data security, and access to digital health tools by rural facilities. The data security is interesting to me because I was reading a stat recently that, and I didn't know this, there's so many things I didn't know.
You have been slacking.
Apparently. Too much focus on just AI. Rural hospitals are one of the #1 targets for cybersecurity attackers.
Their infrastructure is so old.
Now, it's old and they don't have the money to update it, but they're a high value target because of all the medical information.
Well, yeah, they have
security numbers, paying information, billable, all this information about people, very personal information. So they're getting attacked by AI cybersecurity hits. So it's not just because the ransomware attacks now, which is what I meant, not cybersecurity, but the ransomware attacks now are really been focused with AI. Why? They're being focused with AI because AI is really good at getting information about someone and distilling it in a way that then allows you to more easily target the person you're trying to attack. It's not like they're just sitting out there attacking your infrastructure, though they do that too. They probe for weaknesses. They've been doing that a long time. But we get these emails all the time at the school. Click on this or check the bill you didn't pay or have you paid this yet? Or that's the kind of stuff that AI can really hone in on. What is ransomware? It's when you lock down the system and you pay a ransom to get it back.
And then a lot of times what happens is they still take the information that they've gotten and then they go for like the individual family to get them to pay money for something not to be released.
I read about this. There's actually respectable thieves. If you pay the ransom, they guarantee you. The insurance companies even know who they are. If you pay the ransom, they're good thieves, and they actually unlock it, and they don't try to use that information again. That's the good thieves. Now, of course, these bad scumbag thieves, they will, go like you said. They'll attack the families. They'll use like maybe you got a test run you'd rather people not know about at the hospital, and they'll use that to blackmail you and all this other stuff. So there's a bucket of respectable thieves and non-respectable. See, I thought they were all.
So hospitals are high value.
Very high
value. One of the
value.
tech innovations could be to help with that infrastructure.
And utilizing. I use AI at the school district all the time now to help me evaluate my infrastructure pieces. I cannot have a PhD in everything. I don't know everything about the networks and the different operating systems we use. I can't know everything. And I can't, because we're in a small town, I can't afford to hire people that have that level of expertise. So I use AI all the time. They can do the same if they've got the support they need.
Let's talk about what else AI can do for healthcare. Because, we know that this money is going to be something, hopefully, that's going to really help out a lot. But what else can AI do for healthcare? You mentioned something called a Scribe. You mentioned a Scribe.
The AI Scribe is what I think our local doctor is probably using. But basically, the AI Scribe it's a tool that allows you to automate the notes that the doctor takes. And I used to work for a doctor's office.
Yes, I did.
You know how doctors write.
Yes.
And
they, a long time ago, they used to use the tape recorders. And then we had somebody who came in every afternoon and she would sit there and she would type in all the notes.
I remember her.
Yes. And
she was a fast typist.
I can remember one of the things.
Sorry, got a phone call.
I can remember one of the things that the doctor I worked for used to do is after every single patient, he would have to take about 10 minutes in between patients and he would transcribe or speak into the recorder every single time, dictate the notes, because he said
Did they call it a dictaphone?
It was a dictaphone. He would dictate the notes because he did not want to forget the conversation or, what he had discovered in the meeting with the patient. I know a lot of doctors nowadays, they don't do that. And I know that paramedics don't do that either. They could go on multiple calls because you can't just, if you get a 911 call, you can't just say, oh, hang on, I got to dictate those notes or write those notes down from the last call I was on. You know, and so they can go on multiple calls and then they have to try to remember based on their little handwritten scribble what it is they need to put in the notes. So artificial intelligence, because you can sit there and have a conversation with it immediately, I think it's going to really help. As a matter of fact, it says that 74% is what is reducing what they call chart burnout. It's the burnout that happens because you're constantly having to go back and make all those notes.
Well,
so it's saying that they have a charting burnout. It's been reduced by 74% because of this ambient AI scribes.
Well, and it's supposedly giving doctors like 2 hours of time back every day kind of thing.
Right.
Again, you've worked in a doctor's office. You know how much time the doctor spent dictating and how much it cost for this lady to come in and do it. But you also have the problem of, I left a doctor because they were spending too much time on the computer while I was in their office.
They weren't making eye contact. They weren't having that conversation with you. It was
considering I thought I had a brain tumor.
Right. It was a medical emergency.
I thought so, but and maybe in his defense, he was doing exactly what he's supposed to do, but that's not what I needed at the time.
Right.
So my excitement about it has to do with that. But also, what excites me is, yes, there is the potential of it being a tech tax. We talked about that. But I have a tool at school that I've set up that has the ability to do transcriptions. It's incredibly accurate. And I don't have any guardrails set up to where I check the accuracy kind of thing. But if I was going to do that, I would use multiple models and cross-check each other. And I bet you I could get as accurate as a human, pretty much, in this transcription process. The other thing is that I've seen these tools, these image tools, read really bad handwriting like Jared's. And I've seen if they can read handwritten notes and they're extremely accurate on transcription, they can also translate the notes into other languages, so it can be put into chart notes for people that don't speak English. I don't know how those notes end up in I'm assuming there's a lot of massaging goes on before they become notes that the patient can see. But I could see AI being to help with that as well.
There was a person you were telling me about that made a comment about taking his radiological
that was cool.
report.
That was cool.
He took his radiological report. He wrote a little bit of a code.
Vibe coded.
Well, I can't stand that word, but he vibe coded, and he took it and basically took the 26 letters of the alphabet that was his report and had it reduce it down to like 4 letters of the alphabet, like he was a 5th grader, to where he could understand what the report meant.
That's your complicated way of saying he made it simpler.
It made it simpler.
Well, not only he made his own app. He made his own app, and it showed the image of, I haven't looked at it, but it showed the MRI image, and it had all kinds he could ask it questions, he could do, obviously you don't want to rely on that.
No.
So.
But if you have the report in front of you that the radiologist has already said something about, then why not? Why not have it, tell it to you like you're not a doctor.
Yeah.
And that happened again. That happened the other day too. We were just talking about, there was a radiologist that commented on one of my LinkedIn posts about how AI has helped him tremendously, because it's like having a totally new set of eyes on all of the different images that he has to look at as a radiologist. And
that's the trust thing. That's the trust thing.
He still looks at every one of them.
That's the trust thing, because this, you say this all the time. It always follows the money. So you have to be willing to assume, or you have to be willing to hope or verify or whatever, that someone isn't going to be a scumbag and stop using
an actual radiologist.
Actually, exactly. I mean, you and I worry about this in education. We see these schools come in, they offer AI. AI is going to be great. It's going to take the place of teachers, that kind of thing. And that would be fine if they were all hiring PhD level teachers as a backup. But you know what happens when they get pressured to the bottom line? Got to make that bottom line. Got to make that bottom line. So now the radiologist goes, you know what? I'm just going to glance over it, or I'm just going to trust the AI. And if it flags something, I'm going to look at that.
His point to me was because of the malpractice
Trust but verify.
Trust that he had to put his name on it. He had to be willing to, go to court over it. He had to verify.
Like a civil engineer.
And for him, his comment was, because we were having a conversation and I was like, are you afraid it's going to take your job? And he said, no, because he is asked to read a certain number of films every single day. That's his job. And so let's say he's supposed to look at 100 different films a day. It's allowing him to catch things he's afraid he was going to miss.
From burnout,
fatigue. Yeah. And it's given him some time back into his life to where he feels like he can, have a life. And that's something else. In rural America specifically, we are not getting new workers. We are not getting new young doctors that stay in rural America. It has to be a calling for doctors to do.
Well, they have to want to come to a small town.
Maybe their family lives here. Maybe they have a ranch in the area or whatever.
When we were growing up here, there was a multi-generational family,
and they came back.
And they would go off to medical school, and they would come back. And they had at least 3 generations. I saw the grandfather, the dad, and the son. Right. All 3 have been doctors for me.
Right, and now the son is, I don't know how old, but he's definitely old enough to retire.
Oh, he's talking about retiring all the time.
He's been talking about retiring all the time. And the point that I'm trying to make, do what?
Did anybody come to replace him?
No, I do not believe so. I do believe that, if you're a 65-year-old doctor and you're thinking about retiring, and one of the reasons you're thinking about it is because you spend 12 hours a day with not just patients, but then dictating and then transcribing and then, making chart notes at your dinner table, then you might not consider retirement so quickly if you have something that's helping take up that slack. But let's go. Let's talk about the trust gap. The trust gap that you just talked about.
Yeah, the trust gap is... I think the trust gap can be looked at from two areas. One is this idea that you're going to come into the doctor's office and there's going to be a tablet. Remember when we made RoboHead? And basically RoboHead was a tablet attached. It was a robotic tablet. I think that's the wrong paradigm. I think in small towns that there's a trust relationship. It's like me knowing 3 generations of these doctors. One of the doctors I saw when I was a kid, he delivered me with my mom in the local, at the time, county hospital. So you mentioned we have an issue getting doctors here. We don't necessarily trust AI, and we shouldn't. We should be skeptical. We talk about that all the time. But there are some interesting AI-based technologies out there that can make this better. Some of them you don't even need AI. If we can take and make a booth where it looks like there's somebody sitting on the other side of the window from us in a 3-dimensional hologram.
Which they have none.
Which they have now. If you can take and put that booth in, you can bring a doctor in you can have one of these large clinics in the city where these doctors come in all the time anyway, and they spend an hour or 2 working with these rural people, and they do some kind of, cost sharing, or I don't know, it's a good write-off for these big billion-dollar corporations. That's one option. We put a big old donut-looking thing or a big ring-looking thing in the middle of, Times Square or something, and it was connected to Ireland at one. If you can do that, then you should be able to bring a doctor in from anywhere.
Right.
And
they have telehealth. I mean, your mother has a monthly...
Yeah, it's lame.
And we have to get on the phone call, or we have to get on the Zoom call.
I don't want this to be... I'm not talking about being in a home for now. You can't put this level of advanced technology in a home. But you can put it with maybe this rural health thing. You can put it in the corner drugstore. You can have a booth in there where you can go get some doctor consultations in there. You can have it in the doctor's office. AI can do so much. When you walk into the doctor's office, a lot of what you do, the nurse takes my blood pressure and all that other stuff, and she weighs me and all that stuff. That stuff can be automated. And I'm not saying to get rid of the nurse. I'm saying because the nurse can focus on something else. I like the nurse.
She's putting in a lot of time. She's putting in a lot of hours.
She's putting in a lot of hours doing this stuff that she could be doing something else. All this stuff could be gathered and interacted with an AI. How are you feeling today?
What brings you in today?
So you can start the conversation with the AI and let it start bringing up your records so it can do a lot of background stuff. The problem is, we talk about this all the time, cognitive services cost money. And these are expensive services. And right now, they're having a difficult time managing the costs of those things. It's very open-ended when you start using, we've talked about that, where I spent $15 in 5 minutes because I had an agent going off and doing things unsupervised. There are ways, though, and we're doing it at the school. There are ways to put it in less expensively. But what's one of the big problems you have with getting it into small towns? Got to have good connectivity.
Yeah.
So, I mean, there's a lot of things that have to go on, but I think you can bridge the trust gap by not trying to replace the people with the AI.
But that is why also one of their strategic goals is sustainable access.
Yes.
So, lot of that 50 billion, 10 billion a year over the next 5 years can be utilized to try with the access issues that we have, which is, of course, your infrastructure that we were talking about. Let's go right here. We talked about some cybersecurity and stuff like that. One of the things that I am concerned about, and you and I actually have filled out and will hopefully hear fairly soon, a TWC grant that has to do with workforce.
What does TWC stand for?
Texas Workforce Commission.
Oh, okay. Texas Workforce Commission.
We have filled out a grant for upskilling. I know a lot of the people who work in some of these clinics, some of these small clinics, and I think that they're very fearful of technology and changes in technology.
AI technology because they don't know how to deal with it. Cognitive services are scary. AI agents are scary for some people.
Are you thinking that we're going to lose some of the workforce because of this technology?
If it's not done well, yes. I think if we focus on the technology and not on the people, we're going to have the same problem we saw at the school.
I know my father left the Postal Service whenever they upgraded the technology because he did not want to go through the training.
My grandfather was a mechanic. He stopped being a mechanic when they went from generators to alternators.
Mm-hmm.
My dad was a mechanic. He stopped being a mechanic when they went from the old control systems to computer-based control systems. That's exactly the same problem. When you start going in there and you're going, okay, we're going to bring in this new tech, and it's probably going to be done poorly because it's going to be focused. They always focus on the technology and not the people.
Mm-hmm.
That's why we're putting in so much at the school ourselves. And I tell them, what I'm giving you is not perfect. I'm not trying to make it perfect. I'm trying to make it adaptable. But in healthcare, you have to be careful with that. If you make it adaptable and it makes mistakes, there's a different set of consequences. That's why you can't get rid of the nurses and the doctors.
Right.
The technology has to learn to do better, and you cannot afford to pay. You bring in these big companies, IBM or Motorola, not Motorola, but Microsoft or whoever, and they're bringing you these cognitive services. They want to bring you this very expensive thing you cannot afford. So that's that tech tax again. The technology tax, you can't afford it. So how do you do it? We owned a restaurant. We could have hired somebody to come in and set up our point of sale system. Couldn't afford it. What did you do?
I set it up myself.
You set it up yourself. You put in all the stuff yourself, and you got a PhD in point of sale systems.
Yes.
Whether you wanted to or not.
Yes. I think that's what's going to happen.
Okay, leaving out anything?
Well, the one thing also, I wanted to mention the pharmacies. You mentioned the corner drugstore, and I think that was a great idea because we talk about these like screening services that you could do. Mm-hmm. I mean, like right now, we have a dermatology clinic in Atlanta.
It hasn't been open long.
It hasn't been open very long, and they're not there 5 days a week.
Oh, they're not?
They're only there like 2 days a week.
I didn't know that.
And since the time that I have been going there, both of the people I've seen have moved elsewhere, and they now have another dermatologist that's coming in.
Oh, what?
So it's switched too? Yes. So it's switched over one more time. I haven't been there since the new person is coming in 2 days a week. A lot of those types of services, I think, can be screened ahead of time
using AI tools, especially as they keep getting better and better.
Right, like skin cancers and retinal scans. Just
I think
the different
full
things.
Body scan where it looks at all your skin. I've gone into dermatologists before and they looked over.
Yeah, you have a full body check,
and they look over you. I've never felt like they do a good job on all the body parts. There's some body parts they just don't really, depending on male or female, they don't really want to look at certain body parts.
Well, and you don't want to lose show.
And I think having an AI might make you feel a little more objective about it as a first pre-screen. I'm not saying the doctor still doesn't, but it's like you said earlier, it's a tool that you can use.
It's like a triage.
Yes,
it's like a triage tool. It's like, okay, look.
Let's not miss the obvious.
Let's not miss the obvious. Yeah. And like, okay, this one right here, you need to go see your dermatologist like now. or this one, you need to make an appointment. But, and it's, you know, I've talked about it before. Right now, our healthcare system is so inundated with the people that think a hangnail is an emergency that the schedules get so full that you can't get in easily for a true emergency.
Well, you know, the fact is that when your toe hurts, for you, it is an emergency. It's
Definition of a situation.
Absolutely.
If that situation is what you define it to be, then it's real to you.
Right.
So, all right. AI is going to help save rural healthcare.
Is that the question?
Is that our final word? Is that what we're saying?
I don't see how we can do it without it. We don't lack resources. We lack them where we need them.
Yes.
And the problem is that without AI, there's not enough money. I mean, since we are a capitalistic society and healthcare is a profit and loss statement, I mean, think about it. Government tries to help, and what happens is they show less profitability, so they start merging, so there's less competition. The local clinic got bought by a company, that company got bought by a company. It's like bigger fish swallowing the fish. By the time they get swallowed 2 or 3 times, which is what happened here, the service is terrible, it costs more. I don't see how you can manage that without using some kind of new type of tool. It's not getting any better. We're great in this country at emergency services. You break your arm, they can set it. You're bleeding, they can do surgery.
Number one, like strokes. I mean, if you have a stroke.
If you're in the hospital and you have a heart attack, you got a decent chance of living. The problem is that we can't get the services where we need them, and I don't see how to fix that without using artificial intelligence. So will it save it? It won't save it maybe the way everybody wants it, but from a person living in a small town, I'd like it to be, give a shot at it. I mean, what's the alternative? Either move out of the small town.
Which you can't afford.
Which maybe you can't, maybe you don't want to move out of the small town. Maybe you can't afford it. It doesn't matter what the reason is. I don't see how you can fix it without technology. And technology may be part of the cause of all this, but I don't know another way to fix it because I don't know how else to get the resources here. You can video, do the telehealth and all that other stuff, but when you don't mix in the AI sensors and the AI, the burnout problem, for example, if you don't fix that, you don't have enough doctors. If you don't have enough doctors in the city, you're sure not going to have them out here in the rural areas. So you have to, it may save the rural areas just by helping save doctors for the urban areas. But they're in the urban areas, they don't want to move out here. Maybe they're single. That used to be a joke here. You can't get anybody to move here because everybody was married or too old to get married. So single people would stay here for a year or two and then leave.
Right.
And so maybe they don't, but if you've got a AI enhanced holographic booth or you've got a AI sensors in the, take, Jack Franklin's office and have it when you walk in and it's weighing you automatically and it's looking to see if you've got a weird looking stoop or it's measuring your gait or who knows what. There's so many health sensors out there that are AI based now. It's crazy. Take all that, but Dr. Franklin can't afford that stuff. So maybe this grant. Hold on, it's through the CMS. Somebody was telling me what that meant.
Center of Medicare and Medicaid Services.
Okay, I never would have got that. CMS.gov. Anyway, that's where we found this at. And, to me, it's kind of hopeful. I mean, there's a lot of parts to it. And I think there's a lot of people afraid that it's going to end up stopping above the local
levels. It's going to stay at the state level. And not trickle down. So, all right, guys, my name is Maurie. I'm here with my husband, Jim. Thank y'all so much for watching AI in action. We hope that y'all have a marvelous rest of the week.